The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day, all of you TMD warriors. We are here for the next episode of TMD Demystified, and I am Tony Urbanic. Today's topic has been promised for some time, and I'll get right to it, is entitled, "We have been given a phony TMD roadmap to follow." We have been given a phony TMD roadmap to follow. Not intentionally. I'm certain it was unintentional. Some very smart, great men, smarter than me, began this process many years ago, but we're going to talk about that this morning. As I speak, it's on a Tuesday morning, June the 27th, 2023. I'd like to preface what I have to say, first of all, by anything that comes out of my mouth today is not intended to be critical of a person at all. I think some very great people and academicians have worked on this problem since the very beginning. But in the end, on review, having the opportunity to look through the retrospectoscope, which is always easy to do, look through the rearview mirror, it's always easy to see where the fallacy begins and where things begin to get off the rails. In this case, I traced it back, and I could be wrong on this. There may have another avenue, but because I'm an oral and maxillofacial surgeon and my familiarity with the surgical aspects of temporomandibular joint disease and treatment, I brought the entire concept to where it got off the rails to 1969 in an article written by a very smart doctor by the name of Daniel M. Laskin from Chicago, University of Illinois, academician and researcher. And the article is entitled, "The Etiology of Pain Dysfunction Syndrome." And to my knowledge, to my awareness, it was Danny Laskin, who I respect very highly, and who had recently passed, wrote this article in 1969 and published in the Journal of American Dental Association, volume 79, July 1969. If I said, yeah, volume 79 and July 1969. And in it, he described the problem that he was looking at, and he came up with a theory of the pain dysfunction syndrome and myofascial syndrome. And I'd like to just start by reading the first part of the article. And again, I apologize for reading this, but you can look this up yourself if you want to look up the entire article. I have it before me. But at the first part of his article, Dr. Laskin says, according to the psychologic physiologic theory, masticatory muscle spasm is the primary factor responsible for the symptoms of the pain dysfunction syndrome. So he spells out at the beginning that according to his findings, that it is the muscle spasm of the muscles themselves that are responsible for all the symptoms. Now, again, if anyone who has followed me, and if this is your first time watching, I guess I have to apologize because all the information I have to share are seen easily on multiple episodes on this podcast. But what I have found is that the actual common denominator and inciting factor and cause of all the symptoms is inflammation within the temporomandibular joint, which does have an effect on the muscles. But here's where the difference lies, and that is the inflammation causes the muscles to contract, to go into spasm, and then subsequently create pain by pulling on the bone at the nociceptors, and many other symptoms, which we've described, but it is not the cause of temporomandibular joint problems. The muscle spasm itself is not the cause, it is the effect, which creates pain and related symptoms. To continue on with the first part of this article, I'm not going to read the whole article, don't worry, but it continues to say the most common cause is thought to be muscle fatigue produced by chronic oral habits that are often an involuntary tension relieving mechanism. Well, we know that patients have oral habits, clenching and grinding, which are basically the same thing, whether you clench or you grind on the teeth. It is an oral habit related primarily to stress. Now, is that involuntary habit tension relieving? I would question that. I wouldn't say it's wrong, but I would question that it is not tension relieving, that it is produced by tension, anxiety, stress. Anxiety, stress, we know, because I know because I see it, I've seen it thousands of times in patients in my office as we do go through a consultation. Stress, anxiety causes clenching or grinding. But is it true to say that the involuntary tension, it is an involuntary tension relieving mechanism? I don't think it relieves tension. I think there is tension, and then the effect of the tension anxiety is clenching or grinding, which does damage, of course, to the teeth and does damage within the temporomandibular joint, creating chronic inflammation creating all the symptoms. So just to clarify, what I have to say and what I've found in comparison to what Dr. Laskin teaches and what his opinion was and his viewpoint was back in 1969, on his seminal article. I mean, this is where myofascial pain dysfunction syndrome began with that Dr. Laskin and his studies at the University of Illinois prior to publishing this article in 1969. To continue, organic changes such as occlusal disharmonies, degenerative arthritis, and contracture, which may result, tend to make the condition self-perpetuating. Well, as I just said, clenching and grinding will have destructive effects on the occlusion and can create degenerative arthritis and chronic inflammation within the temporomandibular joint. Contractures of the muscle itself, I'm not certain about that. Spasm for sure, but a contracture of a muscle is actually a effect creating scarring within the muscle. And I have not studied, I stand to be corrected, but I'm not aware of any contractures histologically being seen on masticatory muscles under the chronic effect of clenching and grinding. So this is all very pedantic and specified, but I think it's very important because the point I'm trying to make is that beginning with Dr. Laskin and his seminal, iconic article in 1969, the entire profession, certainly the portion of dentistry as known as oral and maxillofacial surgery, has been led down a phony roadmap, bringing us to the point where the actual cause has been overlooked. And myofascial syndrome, as it is known, is not actually a description of what is going on within the temporomandibular joint. I'm going to read one more paragraph about this and then discuss it a little bit more as to the point I'm trying to make. There are two aspects, this is to quote the article, there are two aspects to the successful management of any disease process. One is the establishment of an accurate diagnosis, and the other is an understanding of its etiology so that a rational treatment plan can be formulated. Unfortunately, in the management of many problems involving the temporomandibular joint, we have not been highly successful in either of these areas. Well, he is correct in his question, and that is, that there are two aspects to a successful management of any disease, or a statement to that effect. And one is you have to have a correct diagnosis, and the second is you have to have a rational treatment plan. So the diagnosis, I think, has been eschewed tremendously because of its focus on muscles rather than the joint itself. And the treatment, again, has been skewed by the effect of focusing on the muscles by themselves. So the simplicity is that when you know how inflammation changes, makes the changes, creating the symptoms of temporomandibular joint problems, TMD, it's easy then to make your diagnosis by defining the diagnosis as the symptoms themselves. The diagnosis is the symptoms themselves plus confirming that there's inflammation within the temporomandibular joint. Pretty simple concept there. So we know what the symptoms, the well-accepted, well-agreed upon symptoms of temporomandibular joint problems are: frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking. There are other symptoms that I have discussed and noted prior that are on that list. They're not as well accepted, so I won't mention them, but those are the accepted symptoms. And when you recognize each and every one of those symptoms in concert with the other symptoms or by themselves, they're just red flags in making the diagnosis. And finally, the clinical part of confirming the diagnosis is confirming inflammation within the temporomandibular joint. And the best way to do that is to press on a joint, a knee, a hip, an elbow, and if it hurts, that joint is inflamed. And that is exactly how it works with the temporomandibular joint. So if you have a series of symptoms that are consistent with TMD, and you press on the joint, in this case from the open and the closed position, with pressure, and you elicit pain from the patient, you have made your diagnosis. So that part is quite simplified. The second part is actually having a rational treatment plan that can be formulated. So we got way off the road when we began looking at myofascial and muscles, which began with Dr. Laskin. And again, I I admire Dr. Laskin, and he was the editor of the Journal of Oral and Maxillofacial Surgery for many years. He wrote hundreds of articles, and truly himself is an icon in the area of oral and maxillofacial surgery. And I want to make that very clear. I am not trying to criticize Dr. Laskin, but beginning with this article, the entire concept and direction of temporomandibular joint problems was led astray. And then it got further into the dental curriculum, what part of the dental curriculum, which wasn't much, that addressed temporomandibular joint problems. And it got to be so mystified that things were used for the treatment of TMD that literally did not make any sense. The best example being night guards. A night guard is a night guard. You cannot damage your teeth with a piece of acrylic placed over the surface of the teeth. But a night guard doesn't have anything to do with treating temporomandibular joint issues, especially when you understand that they're related to inflammation within the temporomandibular joint. First thing that comes to my mind is, as if you treat any of these patients, you will hear them say, you know, my night guard actually makes it worse. And the night guard certainly doesn't stop anybody from clenching or grinding. We do not even understand the mechanism for bruxism, clenching or grinding. We know it's a neuromuscular mechanism. It's a neuromuscular mechanism. Beyond that, we're not sure exactly what goes on within the brain, and especially the brainstem, and how all that works, and why stress brings on bruxism, which is definitely related to stress. More people brux under stress, for sure. Basically, half the population grinds their teeth. Most of them are not aware they do it. Many are not aware they do it. Some are aware they do it. Bruxism is a big problem, as we all know. But bruxism and is a cause of damage to the joint. But bruxism, I do not believe, relieves stress. It's an effect of stress. It doesn't relieve stress. It damages structures. So we have been led astray, and it all began with the original article by Dr. James B. Costin, 1934, in the Journal of Otolaryngology. Dr. Costin was a otolaryngologist in St. Louis, Missouri, and the first description of what we now call TMJ-TMD was written by Dr. Costin, and actually delivered to a group of otolaryngologists in Texas in 1934 and published in the journal. From there on, things got dicey, and my intent is to straighten it out. I am not going to belabor this any longer. I leave it to the listener to make sense of the reality of it, the logic of it. We know. I mean, I've been able to prove that if you get rid of the inflammation within the temporomandibular joint by unloading the joint like a set of crutches would unload an inflamed knee, the symptoms diminish, and all the symptoms mentioned diminish. If that is the case, and that is the case, we have proven it. We have proven it actually academically with an independent university study based on 3,000 patients, with surveys on, I think the survey numbers on that initial group were 300 or so patients, that when you unload a joint with a device that separates the back teeth according to a proper protocol, 24/7 for 2 months, and then nighttime for the rest of their lives, the inflammation within the joint will decrease, and whatever symptoms on that symptom list are present will decrease over time. Fortunately, painful symptoms decreasing much faster than the 3 symptoms associated with the middle ear, which are tinnitus, subjective hearing loss, and vertigo, but they also subside over time. They're slower. And then, of course, locking decreases significantly once the synovial fluid under the influence of inflammation returns to its more lubricating values rather than sticky values, which synovial fluid becomes sticky with inflammation. And when the inflammation decreases, it becomes more of a lubricant, and the locking decreases significantly and opening improves significantly. So we have been given a phony TMD roadmap to follow. It's my intention to straighten out that roadmap and bring you directly, easily, with a short, very short roadmap, directly to the inflammation within the temporomandibular joint and alleviate any and all aspect and emphasis on what's going on with the muscles, which do spasm, and they are basically instructed to tighten up to hold the joint still without moving it. Once the inflammation within the joint signals the brain, tighten up, don't move that joint. And the muscles of mastication, then the muscles of the neck, and then the muscles of the shoulder will tighten up and create pain in those areas, which is recurrent and significant in some patients to a great degree. With that being said, I'd like to invite you to listen to the next episode of TMD Demystified, which I will record in a week. I invite you to review some of the other episodes on Dental Town, which I have recorded for the past 2 years now. We are now on this episode will be episode 106. If you would like to discuss anything that I have said, or have any questions or criticisms, I'm available at Tony@tmjservices.net. Our director of marketing and education can be reached at Naomi@tmjservices.net. And I look forward to the next time that I can present another related topic to the temporomandibular joint on this episode of TMD Demystified.